Okay, I think we'll go ahead and get started. Um, Hello, everyone. My name is Becky Ofran. I'm the Manager of Engagement and Partnerships for the City Health Dashboard. Um, so these are our virtual office hours we've been doing for about a year and a half or so. These are meant to be informal ways of checking in with users. We have found that oftentimes it's new users to the dashboard. So if you're brand new, welcome. We're going to start with a kind of brief overview of the City Health Dashboard, and then we're also joined by Paige Kyle from Bronson Healthcare in Kalamazoo, who will share from her perspective. And so each virtual office hours, we touch on a specific topic. And today we are talking about CHNAs or China's. I've often heard it referred to as either. So, and we are also aware that many of you are likely much more well-versed in the CHNA process than we are. We are certainly not experts in it, hence inviting Paige to, to join us today. So we do hope that, there's a good chance for discussion and questions, and for really you all to kind of share with each other as well. In addition to finding the dashboard data useful. And as you'll see, the City Health Dashboard is city and neighborhood level data. And we know that's not always what you need for a CHNA, but it can certainly be helpful for providing context in addition to county and state and, other local data that you're collecting. So hopefully, we'll get your questions answered today. And we hope that if you do need city level data in the future, you happily turn to the City Health Dashboard knowing what you can get there. So I'll pass it over to Sammy Breslin, our dashboard project coordinator, to get us started.
Thank you, Becky. As Becky mentioned, my name is Sammy Breslin. I'm the project coordinator. Let me just share my screen. I've been having some issues with my Wi-Fi today, so if it acts up, just please be patient. It should be working, but we all know how fragile these things can be. Okay. So our goal at the dashboard is to help cities across the U.S. leverage the power of data to improve the health and well-being of everyone in their community. And we created the dashboard with the ultimate purpose of helping mayors, health departments, city leaders improve the health of their citizens. But prior to when we launched in 2018, most data on health and the drivers of health or the social determinants of health were not organized at the city or the neighborhood level, but rather at the state or the county or the national level. And so when we launched 2 years ago in May of 2018, we provided data for the 500 largest cities in the US, but this past spring, which is now almost a year ago, which is kind of crazy, we expanded the reach of the tool to include all cities with a population of 50,000 or higher. And so this has brought our total to 766 cities across the country. And you can see our spread on this slide. And the dashboard was developed by our team here at NYU School of Medicine, Department of Population Health, but also in close collaboration with NYU Wagner, which is the School of Public Service, the National Resource Network, National League of Cities, and ICMA. And in creating the tool, we intentionally worked closely with city partners on measure selection, website development, implementation, and user testing to create this easy to use one-stop shop resource to help create healthier, more equitable communities. And, we're an academic institution, so it was so important for us to get those real world city perspectives when designing the tool. And we designed the tool to be flexible, and it really is, quite flexible in, how it can be used, and really can be used in any number of ways. But we've kind of highlighted here or pulled out these 3 salient examples. So when a user comes to the dashboard, they can, compare health gaps across neighborhood. I've pulled out here life expectancy by census tract in Columbus, Ohio, and you could really see, the outcomes are so different across these 3 neighborhoods, which are right next to each other, but also less than a mile away. And so a resident living in one can expect to live a very different length life on that left-hand census tract compared to that neighborhood right next door. And so the dashboard really helps users dig into those gaps and dig into what could be causing those gaps. Users can compare their city to cities in other regions or cities with similar population, and users can also use the dashboard to set priority and better target resources. And we applied a very rigorous criteria in selecting the measures that we did for the dashboard. I'm not going to go into all of these criteria, but I will highlight just a few. So all of our data comes from national data sets, and what that allows us is that all of our data is comparable across cities. So if you are, looking at high school completion in New York City, where I am now, you know that the way we measure high school completion for that city on the dashboard is the same as it's measured in Kalamazoo, Michigan, or Los Angeles, California. So you know that you're really comparing apples to apples, which is so important. We also wanted our measures to reflect public health priorities and be amenable to local intervention. And finally, I'll just say that all of our measures, all 37 of them, are balanced across 5 overarching domains, which I've listed here. There's a lot of information on this slide, but you can see our 5 different categories: health outcomes, clinical care, healthy behaviors, physical environment, and social and economic factors. And the measures listed in yellow are available at both the city and the neighborhood level, and the measures listed in navy are available at the city level only at this time. And I know that kind of went quick, but I want to leave a lot of time for digging into the dashboard, but also hearing from Paige. And so with that is the fun stuff. I will switch over to our demo of the dashboard. Just give me 1 second. Okay, so now we're going to show you the dashboard in action. So, and now is where I'm hoping that the internet cooperates with me. So the dashboard is completely free and accessible to everyone. All you need is an internet connection to log on, and you just log on to cityhealthdashboard.com and you'll be taken to this screen. So because we're working with Kalamazoo today, you just enter in your city name into this finder right here, and you click into Kalamazoo. And so here is our metric selector. These are the same metrics that I just showed on the previous slide, but they're all listed here. And if you already know which metric you want to explore, you can choose it from this list. Or if you're unsure, you can click View Kalamazoo's overview for a more high-level review of the metric. And so this page lets you see a snapshot of the city's performance across each metric to give you an overall sense of, where the city is thriving, but also where are those opportunity areas, where are those challenges that we're facing. We also provide some demographic information, which is really great. We have a new feature that lets users explore race, ethnicity data, age data by neighborhood in the dashboard. I'm not going to go into that feature just for the sake of time, but it is here, and we can answer any questions about this demographic data later on if you have it. So here, if we go to, let's say that we're interested in maybe looking into excessive housing costs, you can see a little bit more detail about the measure, including where it comes from, the years of collection, a thumbnail image of the data or of the metric, and we can click in to the metric detail page. And so this page shows us how Kalamazoo is doing for a particular metric, but in this case, excessive housing costs. And each metric detail page looks the exact same, no matter what city you're looking at, no matter what metric you're looking at. This page it always looks the same. It has this navigation bar, which leads you through all of our features. And it also offers the user some visual signposts that orient you to what you're seeing. And so just moving down, this scale bar shows the range of values for each metric, but also, the colors signal better or worse outcomes. And so across our metrics, lighter colors signal better outcomes, while darker colors indicate poorer outcomes. And the blue check mark here that's in the circle shows to the user the direction of better outcomes. So for a metric like excessive housing costs, as we see here, lower values are better, while for a metric like high school completion, you want a higher metric or a higher number or a higher percentage. And so that blue check mark would be here. This gold bar indicates the city or census tract value for a metric, and the navy triangle just below it indicates the dashboard city average. So in Kalamazoo, residents, 36.1% of residents are experiencing housing cost burden compared to the slightly lower, the lower average of 35.8% across the dashboard cities. And this green check mark here will be shown when the city or the census tract average is better than the dashboard city average. And then just moving down the page, this is my favorite part of the dashboard, is our city maps. And these city maps allow you to zoom into neighborhoods or census tracts within a city to see performance and how neighborhoods might compare to one another. And so it really helps you visualize quite easily patterns that might exist in your city. So in this case, it's clear that neighborhoods in the northern part of Kalamazoo are experiencing higher excessive housing costs compared to neighborhoods in the south part of the city. And you can also click in to each of these census tracts to get more information, but to easily make those comparisons and dig deeper into what's happening on the ground. And I do want to quickly mention that we offer multi-year data for 29 of our metrics, with some going back to 2013. And if you're interested in seeing that multi-year data, you can just click the year and toggle across those years. So moving along to demographic detail, for about 1/3 of our measures, we provide data disaggregated by race and ethnicity, and some also disaggregated by gender and age. And though we do not provide it for this metric in particular, this feature allows users to investigate, not only disparities by place, but disparities between different ethnicities. And it helps users get a more nuanced, a more complete picture of community health and the types of issues that specific communities face. And so Compare Cities is the feature that we provide that allows users to identify peer cities and compare their performance on a metric in a few different ways. A user can, type in, a city that they want to compare themselves to. So for example, maybe someone in Kalamazoo is interested in how Ann Arbor is doing. And so you can type in Ann Arbor there, and then that pulls in Ann Arbor's data for excessive housing costs. But let's say you don't know kind of what cities there are to compare yourself to. We have this filter criteria that helps users kind of investigate and discover different filters to use to kind of narrow down that list and make sure that the comparisons that they're finding are meaningful. So, we do that by population, size, region, race, ethnicity, also by dashboard metrics. And so let's say, someone in Kalamazoo is interested in looking at cities with a similar population size that also have, a similar Black community. The dashboard has found 14 other cities that kind of fall into those same buckets that the user can explore how those cities are doing. So I can choose New Rochelle, New York, Racine, Wisconsin. And again, those cities are also added to the list. Okay. And so let's say you wanted to look at the relationship between two measures. So let's say excessive housing costs, but also poverty rates. We know a lot of these challenges, a lot of these metrics don't operate in a vacuum. They're all very much interrelated, very much connected in different complicated ways. And so you can click Children in Poverty, and the dashboard allows you to dig into the potential relationships and geographic patterns between these two metrics in a few different ways. And so the first is our metric comparison maps, which shows the values for both measures on the same map. So in this case, these blue polygons here represent excessive housing cost, our original measure, and the red dots indicate the value for children in poverty, or the second measure. And in both of these cases, as I stated before, lighter colors indicate better outcomes. And you can see, a clear pattern emerging on the city's north side where, residents who are experiencing higher housing costs are also experiencing higher children in poverty rates. And so although these perspectives are very important, I do want to just caution that, correlation does not equal causation. But, these visuals, give, again, a more complete picture of what issues certain communities face and how these issues may move together in cities across, in neighborhoods across a city and drive health outcomes. And once you explore your data, you can visit the Take Action section, which provides 5 categories of actionable tools created by organizations and websites that are experts in their field to help you drive change in your community and really take data to action. And when we started the dashboard, before we had this feature built out, we heard from a lot of users who were saying, this data is so great. I've identified, XYZ challenge, but now what? How can I, take that next step? And so we have all of these different buckets. We have over 200 actionable resources across these 5 buckets of find policies and programs, find partners, explore strategies, find funding, and measuring impact. And they're all, really useful tools for users at various, from various different communities, from various sectors who can come to this and use these resources and these strategies in their field or in their city. And you can access the Take Action section either from the navigation bar here, which automatically filters for any metric and city-specific resource, but you can also find it in our main menu here, where you can manually filter by metric and by audience. And then finally, I do want to just draw your attention to our data access page. All of the dashboard's data is available and downloadable through this page in 2 different ways. So we have our CSV downloadable data files, which you can either download the complete dashboard city set, or you can download the data by state. I do want to mention that only the most recent year of data is available in these CSVs here, but we also have, for any experienced or more experienced data users, we do have an API which allows users to pull down this data very, very easily, and our multi-year data is available through the API. And so, accessibility is our modus operandi at the dashboard. So providing, this data and providing, the downloadable data, we really want users to dig deeper into the data, conduct their own analyses, and integrate our data with other local data platforms. We know we're not the only tool that exists, and we want our data to be used in concert with any locally collected data or other data sets that our users might be using. And I think that's a great segue into Paige's presentation. So with that, I will pass it over to Paige. And if anyone has any questions about the dashboard, the features, the data, please either drop them in the chat or feel free to ask it at the end when we have a bit of Q&A time. So thank you. Perfect. Paige, you're muted, Paige.
It would not be a true virtual meeting without saying those words.
Yep, it's very true.
Thank you, Sammy. I just learned something new, and I'm really excited to be using the compare cities and the compare metrics function. So I appreciate you moving through that with us. And thank you for the invitation just to be here with all of you today. My name's Paige Kyle. I work for Bronson Healthcare System, as Sammy mentioned. We are a regional healthcare system across Southwest Michigan, so we span 3 counties. And the CHNA is a topic that is near and dear to my passion, and so I'm excited to be here in conversation with all of you, and just want to also disclose that I am new to this process and always open to new ideas of thinking about it. So whether you are involved directly in the CHNA process with your organization, or you use the CHNA in your community to inform your own work, I'm just really excited to engage in the Q&A with all of you. So thanks again for the invitation and for being here. So yeah, just a little bit of context of who I am and who Bronson is, so all of you can have a frame of reference. Like I said, we span the 3 counties of Southwest Michigan, and each county is very different. So I would say Kalamazoo, for the purposes of this discussion, we'll center our conversation around Kalamazoo. It does have the urban center that fits the criteria of the City Health Dashboard. Calhoun does have an urban center, but it's significantly smaller. And Van Buren of the 3 counties is our most rural community. With that said, that's provided some opportunities and challenges as we think about strategy and how we use data across those 3 counties, especially for the CHNA process. So really excited to talk about that as well if we want to engage in that direction too. So the key things that I want to just talk about today that I've been asked to present on are some learnings that we've had around community health equity, how we've elevated the CHNA process throughout our system, and really ways in which we've been able to leverage local data, how we've been able to use sources like the City Health Dashboard to advance health equity within our communities as well. So, you know, our department is fairly new. We were born out of diversity and inclusion, which was a focus area in HR. And we had a leader who was really passionate about equity, and has grown the department and merged community health and equity and inclusion over the last 4 years. So our department has expanded and now includes mental health, equity and inclusion internally with our staff and employees, as well as the community partnerships that we need in order to do that work. So we think about our department as internal and external, working you know, collaboratively and in partnership as we work to address the needs within our communities. So a little bit about us. I like to, this probably doesn't mean anything to all of you, but I think it's important to just always center ourselves around our own mission of our organizations and ask ourselves, are we living out that mission? For us, we really needed to hold ourselves accountable to this mission and really have some unity around the definition of this mission. And I would say the CHNA process for Bronson has evolved since I've been a part of it, and since the origins of it back in 2010, when it was mandated by the ACA. And it really was an opportunity for us to say, you know, what do we mean by health? Can we really, you know, understand that definition and really break that down? And we as a country have done some learning around this, recognizing that it is truly beyond the individual behaviors and health outcomes that we traditionally focus on as healthcare, medical care. We really needed to expand our definition and recognize that the health outcomes that we were seeing inside our 4 walls were really shaped by something bigger around our systems of power, money, and resources within our communities, and that opportunities to live a healthy life were disproportionate and not equal for everyone in our community. And so what does that mean to really expand our definition and live that out through the CHNA process? And so we did, you know, some restructuring of the CHNA process around really our philosophy, how we were going to approach it, and the language in which we were going to speak about it. And so we found this really great conceptual model to begin talking about this and illustrating what we were seeing in our communities. So this is a really great conceptual model that I borrowed from Bay Area Health and Equities Initiative. And it really just picks the manifestation of health outcomes and disparities that we see. And for us, when we think about health and we know that they're shaped by, you know, upstream factors around our living conditions, around the social determinants, we can then begin to feel empowered to dim the lights on risk behaviors and health outcomes and begin to look upstream and look at what we call the root causes. If any of you are familiar with ACEs and Nadine Burke-Harris, a really great example of this is if you look at, an asthmatic child and really just treat the asthma and don't look at the housing or the conditions in which that are informing that asthma, really we're just treating symptoms and not the root cause. And so for us, it was looking upstream and really focusing not only on the living conditions, but the inequities. And I think the inequities are probably the most difficult piece to really see in data, because it's hard to quantify inequities. They are exquisitely designed in our systems and therefore really difficult to pull out and extract. And so we knew that we needed to also think about that as well. This box of being white, having wealth, being educated, being straight, being able-bodied, being English speaking, all these things, allowed you to have access to that middle box, the living conditions. And, if you were other than, we knew that you were being left out of certain systems that weren't designed for those that were different. And so we took a true, I think, earnest effort as to engage within individuals that are typically left out of this process. So we had equity really driven into our approach and our outcome. We have a CEO who has really called this out with his new leadership, and really appreciate him being able to hold this organization accountable, being transparent with the community that racism exists in our institutions, in our communities, and we're going to work together to really dismantle it. So when we talk about really pulling out the inequities in data, we had to really understand where the greatest needs were. And like I mentioned, in Kalamazoo County, we have an urban center, Kalamazoo City, as Sammy just explored through the City Health Dashboard. And, this was our first, I think, opportunity to say, okay, there's some disparities that exist within our urban core in comparison to the county. So I think it was Becky who said, in the CHNA process, we have to think about the county. However, using city level data can give you some frame of reference and understanding the comparison between your county and city and how you're performing against different indicators. And so we took this index, the social needs index, and mapped it across our 3 counties to really see the areas of greatest need. We saw that the city of Kalamazoo, across most measures, was faring worse than the county. And that really gave us somewhere to look in terms of engagement, and also started piquing our curiosity around the intersection of socioeconomic status and race. And so when we started breaking down indicators by race and ethnicity, we began to see an even deeper disparity. And so we started seeing these relationships, and I appreciate Sammy saying, correlation does not equal causation, but I think we can start seeing that these things are intersecting, not operating in a vacuum or a silo. And then mapping our county by race and where people are living. The green dots represent the Black population, our red dots represent the Hispanic population. This is census tracts across Kalamazoo County. So this was a really great illustration of seeing where people lived and being able to overlay this map on top of other maps with health outcomes or upstream economic drivers to really see, again, this relationship between class, race, and place. And I think it's important to see these connections because there's some historical context around this. As most urban centers across the country have experienced this in the late 30s with FDR and his administration, redlining has really begun to shape opportunities, wealth building within our communities that in terms of where people are living and the opportunities that are afforded to them, this wasn't a natural phenomenon, right? This was done by design. That was institutional racism at its finest, and we see the lasting impacts in our health outcomes today. This is a life expectancy map that we see in Kalamazoo, and again, the 49007 is a neighborhood within our urban core, which is literally a snowball throw away of the hospital in which this hospital stands, and there's a 14-year life expectancy gap. So we start to see these health disparities playing out, and know that the inequities are still very much here and present. So I say all of this because I think it gives us an opportunity to leverage data in an advocacy way. And I say that in the sense that when we're at the table, we can start sharing this narrative and this story and lifting and elevating this up. And having data, I think, only gives things more credence and allows people to see it. Otherwise, sometimes what you can't see, you don't believe. And sometimes shaping that mindset means putting the facts in front of people and really allowing people to process that, reflect on it, especially as key leaders and decision makers in our communities. And so it's also an opportunity for us to look at those disparities within our community, those areas of greatest need, and engage there. And so we did some really targeted engagement. I would say that we didn't engage with a ton of people, but we engaged with the people that we knew lived in the areas that were showing up in the greatest need in our data. And so when we think about equity as a process, that's how we approach this. We really reached out to our Black and Brown communities. We reached out to our individuals with language barriers, with disabilities, and really wanted to hear their story. And so this was a nice bridge between quantitative and qualitative data. So our CHNA was really mixed methods, and we put a heavy emphasis on community voice and the qualitative piece. And so had our community members really prioritize their lived experience, and then took the quantitative data to really supplement and bolster that story. And I think this is really important because you can show this redlining map and the life expectancy map, and I said that there's advocacy here and you can see it, but do you actually believe it? And I think when our community members started coming out and saying, I experience racism on a daily basis, and this is what this looks like for me. There's a complete story there. There's a better understanding of why and how that feels to someone on a daily basis in our community, and how that informs the way in which our systems begin to look at our own policies, our own norms, our own practices, our own culture, and how we can begin to make an impact on that. And then I think it's timely because we're also using this data to really inform real-time action. I'm really grateful for the City Health Dashboard. It's been a go-to resource for me when I'm engaged in leadership conversations around vaccine implementation and community partnerships. The City Health Dashboard has been a resource and has been a model for our IT department to say, wow, this is a really unique way of looking at an index, and maybe this can really inform how we think about our logistics of vaccination sites and our community partners that have to be, lock in step with us in order to implement this. A big thing that came out in the CHNA was lack of trust, and I think trust over the last year has been an overused term. However, it gives us a place to say, what does trust mean? What does that mean for our community members? What does that look like and feel like? And how can trust inform our vaccine rollout? And what did we learn from this entire pandemic around trust? And so it gets us a little bit more granular as to how it informs our interventions and our partnerships, and how we go about implementing things based on need versus what's convenient for us. So the other way in which we use data is through our strategic planning process. So our CHNA is accompanied by an implementation plan. We are held accountable to that assessment process, and we are obligated to respond with an action plan, and that's our implementation plan. It has our implementation plan has more of a perinatal experience focus. We are the South Central and Southwest Michigan only children's hospital, and so we have not only resources there, but we have some really great partnerships around the perinatal life course, and so we know that we can really make an impact starting early in childhood and throughout that mother's lifespan, and really supporting families. We understand the relationship between wealth and health, and so as an employer, we also have a responsibility to think about good paying jobs and opportunities for career pathways. And so I say all this because I think it's also been great to use external data and find that intersection with internal data to really make the greatest impact. And I think that requires infrastructure internally. So we've spent a lot of time with our IT folks thinking about what it looks like to really make sure we have valid fields for race, ethnicity, and language, for sexual orientation and gender identity, and also the social determinants, so that we can be more nimble internally with our data. And also begin to really extract those inequities within our workforce and our own patient care. So if we can start breaking down data and stratifying data by demographics at any point possible and being really quick at that, we can really stay ahead of the interventions when we see disparities that are also inequities. So I will pause there and open up for questions, comments, and conversation.
Thank you so much, Paige. That was an echo there. We really appreciate that overview from Kalamazoo, the great work you're doing there. I have a couple of questions to start off, but and just to kind of clarify, because some questions were coming into the chat. So Paige showed some other county views and other data sources in addition to City Health Dashboard. So, you know, we'll cover questions on anything related to CHNA that she covered, but we can also talk about, you know, specific questions for the dashboard as well. And again, as was mentioned, there's lots of data sources that would use for a CHNA. So we'll cover as much as we can. And Paige, just to kind of start the questions, and others feel free to put some in the chat, or as we pause, you can also just unmute and talk. But you mentioned in your CHNA that it uncovered a lack of trust, and that makes me think kind of unlikely allies in a process like this. And how can data be used to unite the unlikely allies from both the public and private sector, and really foster collaborations, especially when it comes to community engagement?
Yeah, that's a really good question. We've talked a lot about this on our team, and we've come up with the phrase of transferring power. Our communities that are really out already doing the work, and our partners that are ready to engage with us, like, we need to be able, as a healthcare system, be able to sit at tables and be humble learners, and partner in ways where we can transfer that power, where they can, partners can really show us what it means to collaborate and to inform care. So I think about maternal and infant work, and we have a lot of really great partners who are around breastfeeding initiatives around Black and Brown mothers, who have really done a great job of partnering alongside us and thinking about the birth experience from a persons of color perspective, and what that looks like, to walk us through that. And so I think to your point, that building trust, it's such a big term, and that's just one example, right? When we look at the vaccination of our employees and our workforce, and we start to break that down by race, we see that our white colleagues are more ready to get the vaccine and have already been vaccinated more so than our brown and black colleagues. And so I think it's also, an opportunity for us to say why, and not just stop at trust, but what does that trust look like? And then can we then use that information and that learning to then inform, okay, when we go out into the community, we're going to be partnering in this way, so that we can address what that experience has been like. And so I think it's multifaceted, and I think it starts with that transferring of power in conversation and in partnership. We don't know everything, and I think recognizing that there are partners who have been doing this work for decades, who have the lived experience to really help us learn. So that's what I'll say about that.
And just kind of following up on that, is also part of building trust. Sometimes data can help. Sometimes it can help get everybody on the same page, but there's also sometimes bias in the data. And, have you experienced any pushback or obstacles in database decision making? And have you had to really kind of work on that buy-in process with anybody, either through the CHNA process or generally using data for programs and planning?
So I think this is also a really great question. We're of being comfortable. When I say we, I mean the healthcare system. So I'm speaking on behalf of Bronson. I think we are still getting comfortable sharing and being transparent with data, especially when that data doesn't always tell the brightest story. And I think that we are very accustomed with showcasing excellence, showcasing positivity. And I think all of that's really great, but sometimes it's not so excellent and sometimes it's not so positive. And I think when going back to trust, I think you can actually build trust when you're transparent and honest with the data, even when it's not that great. Because I think that's showing your community that you're saying, yep, we see it, we got it, we know it, now partner alongside us and do this with us. So I think that's maybe harkening back to that first question of how do you build trust? Well, I think the CHNA process is an excellent, avenue to elevate community voice, to say, we've heard you, we're listening, we believe you. So I think you're always going to have the people who question data and poke holes in it all day long. And I think, as we all know, data is not perfect. And I think at some point you have to stop and say, okay, like we've collected enough. We've asked enough questions. We've looked at this data from a variety of different angles to really understand this at least to its fullest extent, and know that there are obviously some flaws. But can we move from this into action? Like, I don't think I don't think incomplete data should stall you from acting. I think if anything, it should expedite you into doing something with the community. As long as the community is alongside you, I don't think you can go wrong.
Mm-hmm. That's a great point, and a good segue to Kathy's question here in the chat. Kathy, do you want to just unmute to ask your question or get a little more specific there?
Okay, I'm Kathy Lynch. I'm at Common Ground Health. We are a health planning agency in upstate New York. We serve 9 counties, and we've reported on race for some of our metrics, but we'd like to expand and report race and ethnicity for a broader range of our measurements. But we're finding that it's not always collected, it's not always reported, and it's not really reliable. So we're kind of reluctant to start incorporating it, but we'd like to move in that direction. So we have been, pardon my dog, we have been like asking, how are others doing that? And how have you kind of remedied anything you've come across? So.
Yeah, that is that's been a huge endeavor for us. So the race, ethnicity, and language fields within our electronic medical record, there were a ton of blanks and unknowns for a long time, to the point where we could not display that data with confidence. And so there was a concerted effort around making sure that we were reducing the blanks and unknowns, that we were asking those questions consistently, that we were having standard processes in place. And so we've gotten to the point where we've finally established a really robust way of collecting and reporting out on that data, where we're confident in it. That was definitely a top-down supported effort. We signed what's called the Equity of Care Pledge back in 2018, I believe. And that was an American Hospital Association effort. Some of you might be familiar with it, but it had 4 pillars a part of it. And one of those pillars was preference data. So really understanding that if we're going to achieve equity, we really need to understand the populations we're serving and the populations we're not serving. And so part of that effort was building the data infrastructure around basic demographic information of our patients. And that includes sexual orientation and gender identity, which is kind of our next phase. Because you don't know who you're caring for unless you know, right? So there needed to be a concerted effort around that. But that took resources, absolutely. All of this does. And I think it's probably underestimated in terms of how much resources it requires to build the nimble data infrastructure that's needed to be collecting and rolling up, and the actual analyzing and displaying of that data is a whole nother step that I think our healthcare system is still learning. But I'm curious if there's others who want to chime in to their experience of that.
Yeah, I'd love to hear if others on the call have feedback on that specific question. And just in terms of the dashboard, we also really value being able to display race and ethnic breakdowns, especially of the individual measures. And a lot of times, as Kathy, you have discovered, and I'm sure everybody knows, it depends on how the original data is collected. So a lot of measures that we do display that breakdown for are either from census measures where it's collected at the same time, the demographic info, and kind of as a proxy when that's not available, just kind of plugging back to the demographic maps that Sammy alluded to when she started doing the demo of the site. That at least shows you what's the demographic breakdown of the individual census tracts of the city that you're looking at. So you can, if you're looking at a health measure, say the housing measure, and you're seeing a big discrepancy between different census tracts, that one does have demographic breakdowns. But if you're looking at a measure that doesn't, you can also look back at that demographic map and see, well, who is the population there, and what might be some issues that are causing that. So sometimes there are other ways to get at that, but I'd love to hear if others are, how they deal with reporting demographic info.
I think the other thing I'll add, and if someone wants to interrupt me, please do, but I think what we've learned too is that you don't always have to have the data internally. And I think that's what's so great about the City Health Dashboard is you can use external data to push internal change. And you can also use national data to push local internal change. So I think about, again, going back to our maternal health initiatives, OB, pain, and knowing the disparities of pain management across race and ethnicity of our mothers. That's a nationally known fact that we've seen across race and ethnicity. Have we collected that internally? Nope. But did we have a leader in our OB medical group raise that up to our leadership and say, hey, this is a national statistic. Can we look at this internally and stand up a work group around our pain management with our mothers and look at that across race and ethnicity and see if there's bias that's existing here in our system? Yes. So I think about there's so many different ways in which you can use external data sources to push internal change too.
That's a great point. And sometimes just trying to show, Kathy, you know, where you do have the demographic breakdowns, even if it's showing gaps in other areas, can sometimes help that collection process in the future. Other questions from attendees here? Again, you can put it in the chat or just unmute and ask questions. Otherwise, I have more. So, Paige, for you or for others who have, you know, done the CHNA process or are getting to, also just curious what other data sources you've used that have been helpful. You know, we know, so County Health Rankings is sort of a sister tool of ours, and we know that that's very familiar to folks, especially in the CHNA process. But if there are other tools that you use that are useful, it'd be great to kind of share those with each other as well.
County Health Rankings is my go-to for the county level data for sure. And, you know, a lot of the census data can be broken down by census tract as well. And so I use census.gov all the time as well. And then I guess I speak from an organizational privilege here. You know, we've got contracts with big kind of data companies that give us kind of market share data. SG2 Analytics is the contract company we work with that also gives some really great internal data. And I think by law, affirmative action law, we also get some really great data on our workforce. So I use kind of all of those resources that are at my fingertips as well. But externally, it's City Health Dashboard, County Health Rankings, and census.gov. We have a really great partnership in Calhoun that has its own like collaborative data hub. And so that's been a really great resource to tap into. So, and a really interesting collaborative structure to pull funding from multiple partners to stand up a local data hub like that, especially in a smaller community that isn't getting picked up by the City Health Dashboard. So we get creative.
That's great. And I see some other ones in the chat that people put in Policy Map and CDC Places. And just on that front to note that, so a handful of measures that are in the City Health Dashboard are from the CDC. It used to be called the 500 Cities Project. And now with CDC Places, we're updating those measures. I'm trying to remember how many it is off the top of my head. 8 maybe. But that also means that we're adding those measures for all the smaller cities in the dashboard as well. So we're always trying to, you know, for those smaller cities, make sure that they have the full complement of measures that are on the dashboard. And to your point about kind of data capacity in smaller places, we're also always looking at how to add smaller cities. And we've done a pilot in New Jersey to add 10 cities, all under 30,000 population. And I think most of them were actually under 10,000. So we are building that capacity within the dashboard. So if any other communities, especially when there's a group of cities like that you'd like to explore, we're always kind of pushing that boundary as well when the underlying data allows it. So other options there too. Great. Well, if we don't have other questions, oh, thanks, Julie. I wasn't sure if you were raising your hand, but thanks. We hope this was helpful for you. We record this and we'll post it for folks to come back to if they want. You can always reach out to Paige. Hope that's okay, Paige. And you can always reach out to the City Health Dashboard. Sammy, if you want to put our email in the chat there. It looks like a generic info@ email, but it goes right to Sammy. So we're always happy to engage with users. If you have data questions, if you have an issue with using the site, anything like that, issues downloading the data, please let us know. We're a pretty small team and love engaging with users. Shoshana, Sammy, anything else I'm forgetting? Okay.
Covers it.
Feel free to keep an eye on our virtual office hours in the future. We are doing them monthly, always kind of on a different topic, and always happy to see faces again. So I think that's it for today. We'll hang out if there's any other questions that come up and you want a smaller crowd to ask them in. But otherwise, thanks so much for joining us today.
Thank you.
Thank you.